Now I want to invite our second speaker, Dr. Bharat Vaswani. He is a senior consultant, medical oncologist and hematologist in Yashoda Hospital, Hyderabad, and he will be speaking on localized or locally advanced prostate cancer, oligometastatic disease, the gray zone disease, metastasis or non-metastasis. So over to you, Dr. Bharat Vaswani, sir.
Very good evening, Dr. Asim Samar. First, let me congratulate you for this wonderful conduct of this webinar. Most important thing, are my slides visible and am I audible?
Yes, sir.
Okay, wonderful. So let me start. I'll take 15 minutes, less than 15 minutes if possible. Now, the topic that has been given to me is oligometastatic prostate cancer, a gray zone. So whether you should consider it as a metastatic or a non-metastatic. Now, when this topic was given to me, this was the first reaction when it came to me is like, what came first, a chicken or an egg? So whether you are really telling it is a metastatic or not metastatic, and then I started reading more whether what should I answer this question for. So this was my first impression when I saw this topic, and then I started reading it. And thanks to Samar, that lot of good things I'll be telling you regarding it, something which is new coming up. So why is this my talk different from what other talks I give? Because this is for the first time. I am a medical oncologist. I'll be endorsing other branch of oncology, that is radiotherapy rather than medical oncology. So let me start. So what I'll be telling in the next 12 minutes is, how do I define oligometastatic prostate cancer? How we used to treat, and what is the recent development or what is the recent data that suggests that how we should go about in this disease. So if I have to define the oligometastatic prostate cancer, it is an intermediate state of cancer between a localized and a widespread met. So again, a hypothetical term. But if I have to say in a practical term, what they had defined by Sam Halleman and Vincent Baum is, in a conventional imaging, 1 to 5 mets. So they've tried to simplify it, but please remember, it was not a PSMA PET. It was a conventional imaging between 1 to 5, and it is in between what we call as a localized or a widespread metastasis. Now, for simplicity, this is the way you should remember your oligometastatic prostate cancer. A de novo oligometastatic, which we call as a low burden metastatic hormone sensitive prostate cancer. Now the primary has been treated. See the middle part of it. The green thing is a control lesion, and now we had new lesions, that is 3 or less than 3, which we call as metaconus oligometastatic or a oligorecurrent. And the third scenario is where the patient has already been treated for a metastasis also, and now you have a progressive met. So you can call it a castrate resistant prostate cancer, and there are few metastases. So this is the way we need to understand. This is the way now we are defining it. So these are the 3 types of things. Now, why should this entity be considered as different? Because the data suggests that the survival is better than what you say in a widespread prostate cancer. So if you see to it, this was a trial which was retrospective analysis by Seng et al. The 5-year survival was nearly 30% better when you had less than 3 mets, and that was again reproduced by Sridharan et al., which suggested that yes, if you have a low burden or less than 5 metastasis, your survival is far better and your progression rate is very slow. So how do you treat it? So it is local plus MDT. Please remember, MDT is not multidisciplinary, it is metastatic directed therapy. So this is the most important thing. Please remember, even if it is metastatic, you need to treat it with a curative intent. But there are some differences. So let me start with the first entity, de novo oligometastatic, what we call as de novo low burden hormone sensitive prostate cancer. This is a thing. What is different now? So the first thing and the most important thing is, you need to treat the primary prostate with a local RT, as well as you have to give a systemic disease. So if you have a oligometastatic or a de novo hormone sensitive prostate cancer, which is low burden, or in a first subgroup, you need to treat your prostate with radiation apart from the systemic therapy. And the rationale is that if you treat it earlier, the chances of this becoming metastatic or spreading become slow, and you have an improvement in OS also. Please remember, OS improvement just by treating your prostate when there is a low burden disease. The only slide as a medical oncologist that I am discussing today is, should I use a chemo or should I use a newer hormonal agent? So when you look into the data, docetaxel has contradictory data. Charted did not show any benefit in low burden, but Stampede showed there was some burden, but a benefit. But I will like you to concentrate on these newer agents, abiraterone, inzula, and apalutamide. If you look into the hazard ratio, these are far better than a chemotherapy. So the first take-home message is that if you have a low burden or you have a D-logo oligometastatic, newer hormonal agents are probably better than chemo in this low burden de novo metastatic disease. Now, what is the data that supports this? So two studies, Stampede study and HORAD study. Please remember, a UK study and a Netherlands study. Now, when you look into it, the radiation patterns were different and they were only to prostate gland. So you need not have to treat your bone mets, which are less than 5, but the primary. Just like to look into the radiation. One had 55 and one had 70 gray. Now, when you look into HORAD study, these were new de novo metastatic with bone mets. In fact, they took all the things, high burden, low burden. But if you see, in both the cases, the hazard ratio was 0.68 in a low burden disease. So these was ADT plus minus RT2 prostate only. When you look into it, the subset which benefited was less than 5. And if you look into the hazard ratio, it was 0.68. Now, so there was an overall survival improvement in patient with less than 5 mets. Similarly, Stampede did the same thing, de novo metastatic prostate, but the radiation dose was 55 gray. No improvement. There was improvement in failure-free survival, but no improvement in overall survival. But again, when you look into the E arrow, in a low burden disease, again, the same hazard ratio of 0.68. So basically, both these studies suggested the same thing, that there was overall improvement in low burden disease. To suggest or to solve it, there was a meta-analysis which combined both the studies. There was an improvement, PFS improvement, there is a failure-free survival improvement, but what was more important is in a low burden, there was an OS improvement. So a 27% reduction in the risk of death in this oligometastatic when you treat the primary prostate. So the second take-home message is that treat prostate with local RT in de novo oligometastatic carcinoma prostate. And one thing to remember is if you have to use it, probably these oral tablets, Inza, Apelu or abiraterone are slightly better than what we say chemotherapy, that is docetaxel. So let me discuss the second scenario, oligo recurrent. So this was a patient where you have treated a primary, so it was a localized disease to start with, you have treated it, and then it recurs with oligo recurrent or a oligometastatic disease. In a simple term, less than 3 or up to 3. Now, what are we treating now is we start them on ADT and we may add on any of our oral agents. But what is the new concept? They suggest that giving radiotherapy, if you have a recurrent disease of less than 3 or up to 3 metastasis, improves your progression-free survival and ADT-free interval. So the first trial, STOMP, which was surveillance versus metastatic directed therapy for these oligometastatic disease, it was a biochemical relapse with 1 to 3 extracranial mets on PET-CT, choline PET, surveillance versus metastatic directed therapy. So the primary endpoint was ADT-free interval, and there was 9 months prolongation when you radiated your oligometastatic disease. But the most important thing came in ESCO 2020, that there was a ADT-free survival at 5 years of 34%. Please remember, 34% did not take any treatment when they were radiated with less than 3 mets versus 8%. And a castrate resistant, what we say, free interval was 76 versus 56% at the end of 5 years. So these are good numbers. When you look into the PSA reduction, 75% has a PSA decline versus 35 in surveillance. But please remember, it was not an overall survival, but a ADT-free survival. And probably, I believe you have to give your ADT, plus you have to do a metastatic directed therapy in these. They did not use ADT, which I think was a wrong one. The second study, basically the same thing. Observation versus stereotactic ablative, 1 to 3 mets, SABR versus observation. So what they found out, again, the same thing. In this, basically, it was one step more. At 6 months, that only 19% had progressed. Progression in survival 5.8 versus not reached in metastatic directed therapy. So what they suggested was basically, if you can use your PET-CT scan, it is well and good. Even if you can use in your radiological normal conventional, if you have 3 or less than 3, you radiate those things. What was the summary? Again, the same thing that this is a early data that is there, but you should start thinking of it. So the third take-home message is metastatic directed therapy to be thought of in oligorecurrent prostate cancer. Apart from whether you are using your ADT or you are using your oral, please think of RT also as one of the options, because with the data available, there was an improvement in PFS and ADT-free survival. The last part of my presentation. What if I had already a metastatic disease, but again, it had a oligoprogression. So oligorecurrent, oligoprogression, but it was again 3 or less than 3. So if you look into in this subset, we don't have a clear-cut data. But when you look into your M0 CRPC, if you remember non-metastatic CRPC, Spartan, Prosper, and Aramis study, 29% of these were oligometastatic by PSMA PET. In fact, these were conventional. So you can include this subset, and adding a local oral tablet that is either a apalutamide or an enzalutamide or a daralutamide improves your overall survival. Now, if you look into the different studies, what they suggest is if you have a oligomets, again here, metastatic directed therapy improves your progression-free survival. So probably again in this approach, compared to change in the systemic therapy, MDT can improve your median time to PSA failure and time to next intervention. So a take-home message, the last take-home message is metastatic directed therapy to oligoprogressive prostate cancer. Now you need to consider, apart from your systemic treatment and your ADT. So if I have to summarize my oligometastatic prostate cancer, yes, it is a gray zone. I still believe, but please remember, it is metastatic, but you need to treat it with a curative intent. So oligometastatic CA prostate to be treated differently as compared to local or a widespread mets. And more importantly, there are 3 scenarios. So if you have a de novo metastatic or a oligometastatic CA prostate, please treat your primary prostate, because now meta-analysis suggests a OS environment. Now, if you have an oligoprogressive, the second oligorecurrent or an oligoprogressive scenario, and if it is 3 or less than 3, you can think of giving your metastatic directed therapy because it has improved your PFS and ADT interval. And the most important thing, last but not the least, is multidisciplinary approach is a way to go in these types of patients. I end my talk with a famous quote of William James: act as if what you do makes a difference. Definitely this multidisciplinary approach will make a difference. I thank you all for a patient here.
Yeah, thank you, sir. Dr. Bharat Vaswani, sir. Your talk was wonderful as usual, and we have listened your many talks, and really it was in somehow we will involve in our practice also. So sometimes there is a confusion of what to do with the oligo progression, and it is a real question in our clinical practice, and you answered very well. So thank you very much for your talk. And now I would